Okay, so we're Pennine Acute. We cover 4 areas really. We've got Rochdale, Bury, Oldham, and North Manchester. We consist of quite a large team. We've got 5 consultants, as you can see there: Dr. Bagawadi, Dr. Mukherjee, Dr. Frisius, Dr. Roy, Dr. Zamir. And then the nurse specialists are myself, and I'm not going to read everyone's names out, so it's all there for you to see. And obviously our dietitians and Carol, who's our admin secretary. So that's who the team is. Our project came about because for the last couple of national audits, we were in this area outliers for our average HbA1c. And there were various reasons for that, which I'm going to come to, but we decided that we were going to focus very much on getting that improved. So the purpose really was to look at lowering the average HbA1c by a minimum of 5 millimoles in 50% of our patients by 12 months, but we were aiming to try and do it by at least 75% of our patients by 2 years. We're doing that by various ways, but we decided that we were going to focus on all our patients above 65, so we were keeping it fairly tight, although all patients are obviously being monitored for all areas of improvement. So although we're stating a certain high level, if we look at everybody across the board. Just a little bit of history, which I think reflects on why we're doing things and hopefully why we'll be successful, is the service has undergone massive changes over the last 18-20 months. I came into post as team leader in February of 19, so just 20 months ago thereabouts. Prior to that, the service was 4 separate areas and 4 separate services that were underfunded, understaffed, and being employed under individual children's community nurses. So since me starting, I had the remit of clinically managing the service and bringing everybody into a single service. We got a slight improvement in our budget, so I was able to improve staffing by 2 extra DSNs at band 6, and from there we're kind of just looking at constantly developing and taking the service forward. Next slide. Our improvement journey so far, we felt obviously that the principal improvement is to ensure that the child and family have better knowledge and understanding, and that enables them to make better decisions on their diabetes management. So some of the bullet points here are obviously that team members work much more closely together, and we were able to cover each other's area now. Prior to that, obviously, 4 different areas and 4 different teams didn't really help each other. Frequent team meetings to discuss the service development and continually work on the projects. Working to increase the number of patients who will upload their meters from home on a regular basis. One of the key things obviously is monitoring numbers, so we're getting it's part of our general daily conversation with families are, have you got the equipment, can you upload, will you do this on a regular basis so we can see and share. So we're doing that on a regular basis. Increasing the number who are able to access and be offered new technology such as pumps and CGM. So we've increased that quite dramatically. We're probably about 30% up this year compared to previous years, and that's continually being assessed and growing. So we're using technology more and more. All patients from diagnosis are being set up before they go home to be able to home monitor and upload, and we're using the DigiBete app a lot more and getting everyone to get that on their devices before they even discharge from the hospital setting. We've developed a new and improved newly diagnosed handbook. This offers greater detail on their child's care and support and gives them a very good basis of starting off their journey in managing diabetes. We're developing a high HbA1c pathway, and we wanted to make sure that this was both practical and workable. It's very easy to write a policy that comes up with a grand plan of what you want to do, but we were very conscious that it had to be practical. It had to be something that could be implemented and could be used. We're increasing the number of additional nurse and dietitian care. As I mentioned, we managed to employ 2 more band 6s, and we had some deficit within the dietetics department, which is now being looked at and improved. So we're supporting our families with better staffing levels now. And we're improving our education package, so we're using online resources, and we're bringing this obviously in line with national standards. Most important piece of learning so far, by auditing patients' data and gaining better insight into the logistics of our patient numbers, what their HbA1cs are, that allows us much better understanding of the problem area. We're working as a single team. We're much more able to support each other and become much more efficient within the service. Our service is very diverse. We have a very diverse clientele with many languages. I think we're probably up at about 18 or 20 different languages within our area. So we're aiming obviously to ensure that we have much better access to good language interpretation. As a service, we've embraced the use of technology. We aim to support its use in patients' care, whether it's using a pump or CGM, or just better platforms for downloading and the use of DigiBete and other platforms. We're holding monthly team meetings where we're discussing many things, but QI is on the project every single time. We're using smaller groups who are leading on projects that can be rolled out to the service as they develop them, such as the high HbA1c policy. We've struggled, like many other areas, collecting HbA1cs off patients during the COVID crisis. We are looking at developing better home testing. I'm working with the Path Lab here and at Salford, who are doing some work with more effective and accurate home testing kits. So we're hoping to be able to roll that out certainly by the new year, where we can get a lot more HbA1cs recorded. Much more patient using flash monitoring, which gives us a greater ability to assess estimated HbA1cs. Although we're not using this in some of the data to represent how well we're doing, we're certainly using it as a reflection of how well we feel we are progressing. And the last slide is just to give you a few ideas of some of the tools that we've got. The top left-hand corner is a monthly printout that our secretary does for us that gives us a number that represents how many people are in a higher bracket, and we've broke it down to the 4 different areas. We also look at how many total patients we've got, which is increasing quite a lot this past year. I'm sure all areas have seen the same. And we have an ongoing average HbA1c, which thankfully last month recorded the lowest level we've had since January. So we're showing some improvement already. We have a large database in the bottom left-hand corner, which that's just a snapshot of what it is. It allows us to break down the information as often as we like, with lots of drop downs. We can look at individual patients, but we can look in groups, and we can monitor the data really quite effectively. And then on the right is just a little clinic sheet that we're using. It's something that they take away with them. It's got ideas of what they can look at. It's got rules of diabetes, and it's got a little graph there so that when they get told what their HbA1c is, we don't need to tell them whether it's in the red, green or amber. They can see that themselves, so they can actually look at it themselves and reflect upon it without feeling like they're being put under pressure by us. And that is my presentation. I'll just quickly close that down.